We have many people still joining. We are just to let you know, we are recording this session because there are some people who really wanted to join but are unable to join, so they requested that we record and share with them the recording. We have quite a number of people who had, I think we had about 110 people who had registered by this evening. There are people from many different parts of the globe. We have people from Africa, that is Uganda, Zimbabwe, Kenya. We also have people from other parts of the world, United Kingdom, USA, South America even, Vietnam, India. So we actually have a mixture of many people. And I think, and I really want to say thank you to all of you for joining. And I think the reason why we have these people, so many people today from different parts of the world, is because of our speaker this evening. Our speaker this evening is Dr. Anne Merriman. And I think most of you do know who Dr. Anne Merriman is. There was a poster that we sent that has got information about her, but I'm not going to read that information. I'm going to talk about Anne as a personal friend as well. Anne has been in palliative care for so many years, starting, I think she'll tell us where she started, in some place in Asia, and eventually even coming to Nairobi and being the first doctor, the first hospice doctor at the Nairobi Hospice. She has played a big role in our hospice in Kenya and palliative care in Kenya, and eventually moving to Uganda at a time when Uganda was really facing a lot of challenges with the HIV/AIDS pandemic, and really bringing a solution to Uganda, and not just Uganda, but bringing a solution to the rest of Africa and the rest of the world in terms of improving the quality of life of those who were suffering. Dr. Anne Merriman, if you are going to study in Uganda, you already know about Dr. Anne Merriman. The Hospice Africa Uganda is her idea. She started it up. The Institute is also part of what she has done, and she has reached so many places across the whole globe in terms of palliative care as a service provider, as an advocate, and also as a trainer. So I personally was influenced a lot with Dr. Anne Merriman. When I started at the hospice in 1993, I was doing it as a locum. I had just gone through some personal grief of my brother dying of cancer, and I didn't know what to do about all that. When he was dying, what to do when he was dying. But I was inspired by Dr. Anne Merriman. I said, oh, a doctor is in this profession, and she really inspired me. So I actually stayed on, and we worked together even as we're starting the Palliative Care Association. And I can see Faith is on the call. She knows how that started, and Anne really played a big role in setting up Kehpca as well before Faith came and became the director. So Anne has done so many things and is still doing so many things. I admire Anne because she has not given up to this time. She's still so active. Anne, you're actually the same age as my mom, so that's why I totally admire you. You're like a mother to me, apart from being a mentor. So I just want to say thank you very much, Anne, for accepting to do this session. When I reached out to you, you did not say no, or it's an evening session. You said yes, I'll do it. And we really want to hear from you, because sometimes we forget why we are in this field. We forget the real reason that we are here is because of people. And sometimes we get caught up with politics, with bureaucracy, with the fame and everything. It's good for us to remember why we are here. And I think you're the best person, really the best person to remind us why we are in this field, why we are here, why we're in palliative care. So thank you very much, Anne. I'd like to give you, a go ahead to start your session, because I'm sure it's going to be very engaging and quite long knowing you, Anne. So we will leave all the questions to the end, and welcome, Anne. You can start the session. Thank you very much. My name is Zipporah Ali. I am the outgoing ED of Kehpca. Next week on Monday, I'll no longer be the executive director. I'll have retired, but I'll be there for a month to help the new ED when they come in, whom I'll be announcing actually at the end of this week. And but I hope that I'll still be able to continue like Anne in different ways to support palliative care in this country. Thank you very much. Anne, the floor is yours.
Thank you so much, Zippy, for that introduction. I don't believe half of it, but anyway, it was good. It was good to hear you and to see you looking so young for somebody who's about to retire. I can't believe it. Okay.
Thank you.
And thank you for inviting me to talk about something that's very close to my heart. And just let me know if you can't hear me sufficiently. Okay. So we're talking today about an African ethos for palliative care and beyond. And what we call it when it goes beyond is alumni ethos. And that in fact means that everybody who actually has worked in palliative care should be able to take that spirit with them to wherever they work. And hopefully, not only will we change palliative care, but we will change health professionals throughout the world and anybody who cares. Okay. And the messages I want you to take away today, because I know some of you will not have heard about the palliative care ethos before, but many of you will have, and please excuse me because you'll be seeing slides that you may have seen several times before. But anyway, the message is still there. So we'll be looking at all these into definitions, the spirit, and how does it work today in the difficulties we've had in the last year or so, and how to preserve the ethos in hard times. And can ethos change healthcare? And what do we mean by alumni ethos? And message for the world of carers. So this is the logo for alumni ethos, and it shows two hearts joined together, and the two hearts are equal. It's getting across that our patients are us. One day we will be there, and we need to be, aware of that and always treat our patient as an equal. Too many of us as professionals talk down to a patient, stand over the bed, don't ever make eye contact. And I've been on so many ward rounds in different countries in Africa with an oncologist who talks over the patient and never even touches them. And it's very sad to see that happening. And, things are not improving at the moment, but hopefully alumni ethos may do that. So is this a caring revolution for Africa today? Because if so, it needs to reach the decision makers, the high people and the lower people, the health professionals and families and the family values. The traditional family values in Africa are hospitality. And yet we have moved away from that so often. It's still there amongst the poor, but it's not very much there amongst the rich. So decision makers need to hold the hand of those affected by their decisions, both internationally and nationally. And the international organizations like WHO and the International Narcotics Control Board, they are making decisions that will affect our patient on a day-to-day time. And many of them have never seen what you and I see every day, So our health professionals need to care for the total patient, past, present, and the family. And we must stop refusing treatment to people because they can't pay. I don't know how we can do that, but it's not just not paying them. Sometimes it's paying a bribe to somebody to get into the healthcare system. So it's very, very important that that kind of thing stops, and it will stop if we treat people as our equals. Families will learn from the caring professionals so that the families will care for their patients with the same concern that we do. So the lion and the lamb need to be equally concerned. That's the guys up there and even the community volunteers and the people that we rely on so much to support our services. But do our international country leaders need a heart transplant? We need to change the bureaucratic regulations that favor the poor and suffering, not just the rich, so that we will favor the poor. We will favor the poor and suffering, not just the rich, because the rich are insured, but the poor that need that kind of insurance are unable to afford it at the moment in most countries. A few countries have it. Taxes need to help the poor. 80% of our population are in the lower income brackets, and the taxes that we pay need to be going to them, not to buying big cars for MPs and things like that. Is the money accumulation private or public being given for care? Is it ever going to the poorest? It needs a change in the policies from the highest. We will all die and we can't take it with us. We can't take our money with us. We may as well be helping the people around us now. So how did the ethos come about in Hospice Africa? We were, from the start, we were learning from Ugandans, patients and dedicated people like Rose, who is there looking young and beautiful. And that's me looking young and beautiful. And that's Betty, who has since passed on. That's Mark, who has passed on. And this one, I've forgotten his name now. but he was our general worker. And that was our very first car that was given to us, a 10-year-old Land Rover from the British High Commission. Okay, but after 7 years of working together and after learning so much from the Ugandan people, we were able to see the connection and inspiration from the gurus in the past, and the relationship that there should be between me and my patient, between me and my team, between me and other organizations. And you'll see that as we move forward to look at the ethos. Now, just to go back to the vision of Hospice Africa, which was made at the same time as the Constitution in 92, we came to Uganda, having chosen it as the country for the model in 1993. And our vision is palliative care for all in need in Africa. So Hospice Africa Uganda is the hospice in Uganda, but in fact, our vision is to reach everybody in Africa if possible. But of course, you can only do that through your colleagues and the other people that you meet that are doing this in every country. But the clinical service has to be suitable in each country to the economy, the health service, and the culture of different countries and the areas where they live within each country. The training and education in palliative care needs to be at all levels. And Hospice Africa Uganda now has an institute bringing people up to master's degree in palliative care. But Uganda was chosen as the model, and palliative care came in 93. And I'll be telling you the reasons for why we chose it as we move on. So what is the ethos? This is our ethos. We look at three things. This leaflet on the left, that is our leaflet, and it was last published in 2014. And it gives you quite a lot of detail in there and shows you the spirit that we have. But I'll be looking at this one in a minute again. And there's 3 pillars for the ethos: caring for the patient and family, caring for each other, and support with partner organizations so that we are working together. And this is Bishop Kevin Dowling, who came to us in 2008 and spent a whole week speaking to people in different contexts, from the clergy down to the people who had HIV and also their carers who also had HIV. But he spent a long time before he came reading the ethos. And he said his summary of it was, hospice ethos is full to overflowing with values which reveal a spirit. It's a way of living, of being, of relating, of acting. And once you have that hospice spirit, it will also affect not only how you manage patients and how you work with each other, but also with your family. Things will change with your family once you have got this spirit of sharing. So what values do we follow? We followed the values of Dame Cecily, and hers were ethical and humanitarian values. And she recognized the spiritual dimension of illness and dying, which we often do not notice. She also valued integrity, which means that the people that work with it need to have integrity, and I'll describe that in a minute. In solidarity, support of each other and networking, and interdependence. No man is an island. We can't work by ourselves. We won't get very far if we do. And then autonomy for our patients, so that they can make decisions in everything for themselves, and we're not dictating to them. Integrity is defined in the dictionary as the virtue of basing actions on an internally consistent framework of principles. That means that the person has principles, and I define it as what you see is what you get. If that person tells you something, you know it is true, okay? Because they have integrity, okay? And what are our principles in palliative care? Where can we find them? And are they written down? They're very often not. And I think it's important that every organization writes down their principles to suit the people that they are serving, as we are all in so many different situations. But we have to remember in Africa that more than 90% of cancer patients do not reach treatment in African countries. Many of the people that have survived have left the country. There is a very small percentage that survive, but it's a struggle because many of them arrive far too late because they were raising the money for the bus fare, selling their farm, selling their livelihoods, taking the children out of school. They've gone through so much to bring that loved one to get treatment. But sometimes it's just late. And 50% or more of Africans do not see a health worker anyway. So they're living in the community and expect to die in the community without much help. The populations in Africa are increasing. It's doubled in Uganda since we came in 1993. And Uganda has a very high population under the age of 15. It's something like 48%. And it's there's very little birth control going on as far as I can see. Anyway, the population is increasing, but medical services have increased, but they're not keeping up with the population growth. It's happening so fast. And doctors are very few. And where are our doctors? Many of our doctors, even now, people are going into medicine so they can become parliamentarians and get a big salary. And we got that information from students in one of the medical schools, okay? So doctors are few on the ground, and many of our doctors are actually sitting in a nice, big, comfortable room, dictating to everybody else what they should do and not really seeing patients anymore. Who is actually caring these days? We need to be more caring, and I think our ethos can bring that about. Lower middle income countries, we may be stuck. What can we do? Here we are, we're in a country, they've never heard of palliative care before, and we're trying to introduce it. But we can use whatever inspiration we have. Remembering that 50% aren't going to meet a health worker, and where are they going to die? Dr. Kehpca did a research on that in 2001 or 2, and that was published in the BMJ and then taken up by WHO and continued in 5 other countries. And the result of all was, if they had a service that could reach them in the community, they wanted to die in their own homes. And Dame Cecily says the patient should die in the place most suitable to the patient and family. So we only learn these things when we know the history of palliative care in the world, in Africa, and in our own country. And many of you are making history now in your own country, and it should be documented. It's the beginning days that teach you the most, I think. And each country needs a champion who will stay and be a beacon for those who follow. Now, that doesn't happen very often. You really need somebody very dedicated to stay with them and to help them through. And this is not my words. This is Dr. Janis Joanfat said this when he was the palliative care lead in WHO. He says there is a great need for champions in every country who will carry through the ethos and what palliative care is all about. So how can we uphold all these values that we want? Well, we uphold them with pillars. And as a pillar is a strong support that holds us up in any situation. So we don't just have the ethos, we have the 4 pillars of ethics. Now, we clinicians have all taken the Hippocratic Oath when we graduated, but I will just be showing you how we're not all keeping to those these days. So the 4 pillars of ethics are autonomy, that's patient choice and control of what they do. Do you get that in a hospital? The word hospital, by the way, comes from the same core as hospice, and it means hospitality. But where the patient doesn't have choice and no control, they're just automatons. Get into bed, change your clothes, let me examine you. This kind of thing, it goes on, ordering the patient around as if their brain is sick as well as their body. Okay, then beneficence means we will always do good. We will always do our best to do good. And then non-maleficence, minimize harm. Try never to hurt anybody. And then justice, that means that the use of available resources, balancing the needs of the individual with the wider society. And I put this picture of many of our patients are living in dwellings similar to this picture. And this is so different to what you might find in Western countries. Now, the Hippocratic Oath came from Hippocrates. And you see here, a very wise thing he said, it's far more important to know what person the disease has than what the disease the person has. So what he's saying is, you really won't get to the base of the disease if you don't know what kind of a person you're dealing with, okay? Now, that was 460 BC, you see, very long time ago. And I'll be showing you a short video shortly of Jovia, who was one of our patients, who was, you know, she too lived for a very short time, and she died in 2016. I'll be talking about her in a few minutes. So love and compassion are linked together. And we get this in the major religions. In Corinthians, we all know though, chapter 13, most of us know that about love and the beauties of love, often read out at weddings and things. Have we lost the compassion that brought us into the caring professions? It's so easy to lose the compassion. We find medical students coming in to do medicine because they want to care for people, and they come out the other end wanting to raise as much money as possible. So, you know, what are we doing? How can we keep that need to care within them? Now, this next one is taken from the Quran, and we were privileged in Hoima last week, in Little Hospice Hoima, to have a sheikh join us for our day of reflection. And he gave us some excerpts to show the compassion that Muhammad had. And one of his readings says, God was kind to the prophet, the emigrants. Think of the emigrants nowadays, and the helpers of the faithful who followed him in the hour of distress. When a section of them were about to lose courage, he turned to them in his mercy, for he is compassionate and kind. So there is compassion within the Muslim religion. It's, in fact, it was found as the common denominator between the Jewish, the Muslims, and the Christian religions by a study done in Jerusalem some years back. So love brings solutions for our patient. Then we see their total pain. It's not just their physical pain we're going to look at. We can see the total pain. And once we've controlled physical pain, we can address these. But we promise them that we will never leave them. And, you know, unless they want us to stop seeing them, that's another different thing. But we always say we are there for them. So compassion in action, we give the example of the Good Samaritan, who came on his 1-horsepower vehicle, which was a 1-horse, and he finds this man lying on the roadside with a wound from he's been beaten up and everything stolen from him by the local people. Now, the Samaritan wasn't even, this was in Israel, and this Samaritan was from a different country, but he was the one that came to the patient and poured in it. You see, the only alcohol he has is a bit of wine he's pouring into the wound to try and clean it up. And then he puts the man on his 1-horsepower vehicle, and he goes and takes it to the nearest place where he can get help, which is probably the local inn in those days. And if we look more closely at this, we see that this is very relevant to us today, because the time we're spending with the patient becomes less and less as things come forward. And if we look here, we see this man, he's on his mobile phone. That's what many of us spend more time on, the mobile phone, than we spend with patients. But of course, during COVID, when we couldn't see patients, it was our only way of keeping in touch. But otherwise, even before COVID, the phone was the big thing for everybody. And here we see this guy rushing off to the next meeting, because meetings are taking over from the time we should be with our patients. And this can be very hard as well. So now this is Jovia that I showed you alongside with Hippocrates, and see the difference that kindness can do. Oh dear, sorry, that wasn't very good, was it? Let's see what's going on here now.
So we're going to visit Jovia. She's 20 years of age. She has full-blown HIV/AIDS and cervical cancer. She's become really ill in the last month. She's very near end of life. So hospice has been visiting her very regularly to make sure that she's comfortable and peaceful, and that she has enough morphine and food and money for supplies. So we're here today with Nurse Rose Light, who is her main carer, and to check on her.
Yeah, my grandmother.
Your grandmother was named Jovia.
Yeah,
And you were born here in
yeah,
Kampala.
yeah. There's a lot of dust, fake houses, there's a lot of diseases, everything. So, but we love Kampala because I grown up from Kampala.
How old are you?
No, 29.
29.
Yeah,
And how old's your daughter?
because now she's becoming 14.
14.
Me? Yeah.
What kind of cancer do you have?
I don't know exactly. Maybe I see cervix.
Cervix cancer?
Yeah, I don't want to miss life. Maybe I don't want to miss everything. You people, I don't want to miss you. I want to stay here looking after my child. I want even to do some works because I'm still young. Yeah. I'm even to look after him. Even these eggs are coming me, but soon. Yeah. This medicine are helping me very much. After 4 hours, I take 4 milliliters. So I thank God for that because I didn't know that I'll get it that period. I thank you people to come praying for me, to support me. And because I didn't know I will get you people. That's bag of mine. And there is another one from my daughter. But I'm the one looking after them. And you people need. I don't have someone who look after me. I don't have someone who care for me except you people. And people in the area maybe. But others I don't have. My mom died when I was 4 years. She died when my mom is delivering him.
Access.
Yeah. This video was made by IPRI, International Prevention and Research Institute in Lyon in France. They came over to make films of different things. And this was part of a larger film called The State of Cancer in 2015. And when they showed that at their conference, people were crying, you know. It really struck them that palliative care was so necessary because most of the people at that conference were oncologists who just see them in, and once they go out of the hospital, they don't know what goes on at home. Okay, so let's go back now to the other pillars. We've done the ethics. Now we'll look at the pillars of our ethos. So let me move on and do them one by one. Okay. But as we do them, we must remember that the thing that binds us together is the hospitality, meaning that we welcome everybody who comes in to hospice. And that's what they tell us. They feel it's not like any other health facility because they're treated as guests, from the man on the gate all the way up to the doctor that they're going to see or whoever they're going to see, the clinician. And this again, I will talk again, it's about the context in which you're delivering these three pillars. And this is the patient and family in the center of everything we do. And then what outcomes do you expect from this? And we'll talk about that as we go on. Now, what happened in COVID with the Hippocratic Oath? Well, autonomy, patient choice and control. No, patients were told, if you get the symptoms, come to hospital. And what happened in hospital? They were admitted without their relatives. Now, in most African countries, there aren't sufficient nurses. And so who does the washing and the taking to the toilet and cleaning them up and all that and giving them a drink? That's the relative. Now there's no relatives in. What happens to them in there? And then they know that this is a dangerous disease, that they could die, but they're devoid of their relatives, of their loved ones. I think they should have had patience making those decisions. Anyway, then the second one is beneficence always do good. But some of the things that we did with the lockdown caused more harm and may even have caused more deaths because it was so difficult to reach healthcare. And in fact, many of the other specialties, you know, were denied help because all the help was going to COVID. And that wasn't just in Uganda, that was everywhere. Uganda didn't get it so bad, but you know, it was happening all over the world. Minimize harm. Now, remember that COVID cannot be cured, okay? You can only control symptoms. And who are the specialists in symptom control? It's you, the palliative care people. And you're going to be seeing that huge percentage of patients who will not even reach the hospital. And you're the ones that are going to see them. But where did the money go that came in for COVID? It went into intensive care units. Now, if people had the choice, I don't think they would have chosen to go there. And they certainly wouldn't have chosen if they knew what an endotracheal tube was. Because once you've got that in, you can't speak, you can't think, you can do nothing. So it's really very, very difficult. And then what was just justice? Fair use of available resources, balancing the needs of the individual with the wider society. But people who were insured were getting in very quickly into the hospitals or getting their treatment very quickly, whereas the poor people, some of them died on the road trying to reach a health facility. So, you know, again, this is where we need people who have seen what's going on to be making these major decisions. And this is on the front of our leaflet, and it's a quotation from an epidemiologist. Now, we often divide medical people into, well, the medical people are one thing, but the epidemiologists, they count the numbers and often count the money as well. But how can I understand a figure or a statistic unless I've held a hand that it represents? So he's saying that he cannot recognize that. And I think we all know that. You have to have held hands with somebody to know what is going on. And he says the people we are talking about are the same as us. Now, this is where we see the two hearts together. We are equal. We're all going to face this someday. We'll face illness someday. By the way we treat them, we know just how much like Jesus we have become. And this is by an epidemiologist who works in the Christian hospital in Vellore. And he's an epidemiologist, okay? And he stated this in 1996, and we got this from Gillian Patterson, who was very involved with HIV/AIDS at that time. Now, what about the patient and family? It's so important that we are there for them and that we understand them, because it's only when you see the family that you understand where this patient is coming from. And people who see them in hospitals, they don't know where the background is, and they don't know where they're going back to. And it's really quite difficult. We'll be talking about this little girl in a minute, but morphine has changed palliative care in Africa, because when we came, there was only 3 countries had palliative care, because those 3 countries had morphine, but the other countries didn't have it. And what's more, we struggle with the governments to allow it to come in, to allow the power to come in, because this morphine is so cheap. It's still the price of 1 loaf of bread for the bottle of 500 mils of the green, which is 5 milligrams per 5 mil, as you see in the picture. And this is, we are manufacturing it now for the whole country from Hospice with a public-private partnership with the government. And in the picture there, you see Martha visiting a patient with the bottle of morphine there and explaining to her how to take it, sitting out on the grass. And I think I see some cows in the background there too. So can this formula reach all who care? Not forgetting the love that we need to add to the formula. So why do some health workers treat patients badly? Do we believe we're superior to them? And that's what it looks like. Who has the most knowledge of my patient? Is it me, who've just met them, or they themselves and their family? Do I listen to them, and do I hold their hand? And Dame Cecily said, you matter because you are you, and you matter to the end of your life. And that's what we take, the message we take to them. We will do all that we can, not only to help you die peacefully, but also to live until you die. But if they come into hospital and go out, we never see what happens. And sadly, our health professionals, both nurses and doctors, are trained in hospitals, and most of them have never seen anybody in their own homes. Morphine is so necessary, but only the entrance to coping with total suffering. Because once we're through that, once the patient and the family have stopped being so obsessed, you can actually talk to them about the other problems facing the end of life. And many of our patients are very advanced when we see them. But Ubuntu was there before. We all came in with medicines and with religions, etc., etc. And Ubuntu is very special. It was the traditional beliefs before the religions came in. But this picture is a picture of a fable where an expat, a Mzungu, came in to a village, and he put goodies under the tree, and he said, come forward, as many as can go first will get what they want from this pile of food. And when he looked around, it was children actually. Not one of the children had moved forward. And when he said, he couldn't understand what had happened, because if they did that in their own country, there'd have been a mad rush under the tree. And they said, because we can't do anything by ourselves, we do it together. And this is very important for us. And the patient says to me, as David Tasman said to Dame Cecily, I want what is in your mind and in your heart. And remember, we all have wounded hearts, and it's from our wounds that we learn how to manage other people when they are wounding. So this to me, I think, is very important for us to remember. It's not just the knowledge that we have that we got in medical school or whatever, it's what is in our heart and the love that they're looking for. Now, this is a little girl, let's call her Mary, that one of our nurses, Jane, went to visit in Hoima district. This was the house, the door was locked, but when the little girl heard that the hospice car arriving and heard Jane's voice, she started to cry. She was locked in by herself, the mother had gone to market. And when she came out, this is what we saw. A squamous cell cancer, which was metastasizing all over, and you can see how thin she is. But the little girl was wanting to see Jane, because Jane, it wasn't the morphine she was waiting for, it was the bottle of Coca-Cola which Jane had bought for her on her way. And this is what we call going the extra mile, knowing what a patient wants and trying to get it to them, even if the money isn't there from your employer, that you would use the small bit of money of your own to help a child or to help somebody who has a last wish or a wish for something. And that's the mother behind it, and who the neighbor went and got her from the market. We need to show that we care. And why am I the worst at demonstrating love? You know, we were told, I was told in my day, because I graduated, what year? God bless us, 1963. And what am I worst at demonstrating love? Because we're told, don't get close to your patient, don't get emotionally involved. But you have to. If you're going to give your heart, you have to. Has humility or pride taken over? So this lady, I met her in Sarawak with Dr. Winnie and Lily, who were starting a new hospice. And this was in the palliative care ward. But she was saying, I need your touch and I need your empathy. I need you to recognize my spirit needs as well, because I am me and there's no other person the same as me. The lessons that we have learned in these troubled times are, we need to look ahead and prepare with the ethos in mind. If we cut the catchment area, then we need to do it slowly by reducing new referrals. Be aware of total suffering in the communities and among those struggling to study on reduced or stopped income. We can't just think of ourselves. You see, everybody is short of money. Even before COVID, palliative care was considered the lowest need in health. Cure has always been the big need for them, the people who are treating them and all the researchers. But you know, now this, once the money went down for the donors, it went down for palliative care. So we must never let a patient suffer, never let a student suffer. To be hospitable, to be welcoming is essential for palliative care. So the Ubuntu means I am because of you. Alone, I am nobody, but because of you, I am there. And this is a simple way of saying it, but it has a much wider meaning. And now let me see, Bishop Tutu here and Mandela there, they both talk about Ubuntu. And they said it's the care for each other. And they said, Mandela said, when a stranger appeared in a village, they would immediately give him a room, a bed, and maybe even a lady in the bed to keep him warm at night. But they would all look after him. And, you know, it wouldn't charge anything. He was a guest. And that's hospitality. And it includes respect for others and hospitality all around. So these are some patients that have been found in the communities without ever had any health care. And when we see them, it's my suffering, my care. And that can become very personal as we move on. And this is in the days of Kehpca's sarcoma, when it was rampant in Uganda. When the lady with the cancer of the breast is our second highest cancer here. So secondly, we care for each other. We have to be together as a team. We have to understand that not only do we relieve pain, but we don't inflict it on others at all. Palliative care is different. It's not the same as other health facilities, healthcare. We cannot cure dying, and no research will ever cure dying. This requires knowledge, heart, and respect for each other. So there are special people that we need to be cared for. We need, each of us, we need to support us financially and to help with caring. So many are in need of care. So we need the volunteers, the community volunteers who are trained in ethos and basic palliative care, additional professional team members who care and come and volunteer, general workers, students, experiential. Now, we never know. Many of those people who come to volunteer, even if they don't seem to add value at the time they're volunteering, many of them add value sometimes years after they've gone. Recently, we received a very large donation, and the person who was responsible for getting that for us said that he volunteered with us when he was a teenager. You see, these things matter even in financial terms, but they also matter in they change lives. They change the personal lives of our team members and our volunteers and our donors, because the donors oil the wheels for us, and we can't continue without it. We've really learned that. Board members, they must be chosen carefully for their integrity and their care for the sick. Founders who hold the vision and are there to support the founding vision. And for that to be passed on when founders go, it's a very important thing that happens. And all from the richest to the poorest must feel welcome from the gates up to the care that they're going to receive. And the last one is supporting partner organizations. It's the hardest, but it's the most necessary. We must all know the basics of palliative care to have it in our hearts. It is the love and sharing with each other that lets us grow into dedicated clinicians. We are not rivals. We must share and learn from each other. And the COVID-19 experience has brought us together. So we want to thank the Palliative Care Association of Uganda and Kehpca for bringing us together so many times over this period. It has really been a great learning lesson for us. So if you want to go quickly, we go alone. But if you want to go far, we go together. And that is not some wise old man. This is an African proverb, because we are African and we must remember we are African. The problem with the COVID regulations was that we were following what the West did, but we're not like the West. We're completely different. And African problems need African solutions. And they are there. You've just got to go and look for them. So why is this one the hardest of all? My experience in UK was the first time that I ever saw hospices rivaling with each other, because they were all after the same funds. And you tend to say, well, we're better than them. We've got this one better than that. Please don't give the funding to us. No one had ever heard of palliative care when we first came here. There was no rivalry. We were the only kids on the block. But then others commenced, and they commenced in those different services that I've described there. I'm going a bit fast because I realize time is coming to the end. In 1999, Kehpca started an app, then commenced in 2005, and the palliative care unit in Makerere started in 2008. But we were all after the same pot of money. And initially we had quite a struggle with each other. It's beginning to iron out now, but it's something we need to watch. But we must learn daily from each other. And there are millions in need, and people need every one of us that is caring. And we need to share, guide, and promote each organization. So if we look again at the ethos here, and we're looking at the context now and the outcomes, the context changes all the time. What a different world it is since 1993. What a different country is Uganda since 1993. Our service has to adapt to changes in the economy, terrain, wherever you're working. For example, for us, we do home care within a confined space, whereas Ginger Hospice has people in far away, and they go out and stay a night or two somewhere so they can visit all the patients in that area. And this is the way things are adapted according to the needs. The social class, the divisions, and even wars may come up. How are we going to manage if we had war? And why was Uganda chosen in 1993? Because it was poor, but everybody was supportive of each other. They'd just come out of war. It was the lowest in corruption. They had a promising and popular and trusted leader. And, you know, we knew that we would be able to get finances. And in fact, we managed to, with our donors up to 2015. It was after 2015 that problem started. Now, what about the outcomes? According to a 5-year plan, only God knows where we'll be in 5 years. But anyway, we try to do it because the donors want it, so we do it. We cannot foresee the future, though. The only certainty we have is that we're all going to die someday. And we've come into the world naked, and we're going to go out naked, no matter what we've saved during life. So time can change hospitality through the vision and the ethos. If things happen within the organization, if there's a change of leader, a loss of champion, bureaucracy in government health facilities and others, moving trained team members to other specialties without palliative care, that's happening all the time in hospital palliative care teams. Bureaucracy leaves no space for time needed to provide to the patients. Palliative care is not considered as a specialty in many African countries, even Uganda. Senior colleagues who advise government are not trained in continuing medical education in palliative care, and they don't realize that it's now acceptable to use morphine for severe pain. Palliative care teams are considered as handmaids to the oncologists very often, and lack of adequate training for new members in a different philosophy needs to be done all the time, because most people are coming from bureaucratic organizations which have a different approach and with a different result for the patient and family. We had to cut our coat to match the present situations. Since 93, we had daily home visits, weekly daycare. And in 2000, we had outreach programs and roadside clinics started, and Christmas parties were there for patients and families, comfort for the fund for the needy, and a salaried team. And during COVID, the visits were reduced, the daycare stopped, outreach was reduced, roadside clinics were necessary, but not as often as before. Christmas parties were off, we couldn't afford them. We reduced comfort fund in great time of need, and the reduced salaries and layoffs of professional palliative care people. It was so sad to see our loved team members having to go. So, alumnus, our outcome here, what do we want if we have alumnus? Every person involved with caring or with making decisions that affect the patient will keep in mind the effects on the patient and family. That's what we want to do. Their total needs will be the center of all decisions, no matter where we are, whether we're the lion or the lamb. So can we set up a community of alumni ethos within Africa and the world, demonstrating this change of approach to caring? And what I'm trying to do in Uganda, that will get everybody that ever worked with us or has worked in palliative care and is working with the ethos, would, even when they move into a bureaucratic situation, will try to introduce our ethos so that patients will receive a much better care. What about spirituality and ethos? To be aware and talk about the spiritual state with the patient, we have to be spiritual ourselves. And whether we don't have a religion, we are still a spirit. Because when we die, there's the body. It doesn't need a doctor anymore, does it? Because the spirit is gone. That's why the spirit is so important. But we reach our God through our dealings with others. And that's how we will be judged, on how we help others. And I personally need to practice talking to my God, seeking help in difficult situations, remembering he is with us, because this is the work that is recommended by the founders of all religions. So the ethics and ethos have come from Dame Cecily mainly, and they've gone into Africa, in different parts of Africa. But morphine, remember, is only an entrance to cope with total suffering. You are called, you have all been called, and you have been gifted to help suffering in Africa, and that's our privilege. But you must have the values that we've discussed. Jovia passed on, and this is a song that we sing very frequently. When my life is finally measured in weeks, days, or hours, I want to be free of pain. I need to be free of indignity, free of loneliness. And it goes on to asking, help me to understand, help my family to understand, because the patient is losing everybody. The family is losing one. And we often forget that, the struggle that these patients have. You could tell by what Jovia said, how much it meant to her. So again, Hippocrates comes in, cure sometimes, relieve often, but always comfort. So we must comfort for people and care for the people that we work with, our families and our communities, and caring for those in other organizations, those who ask us to help them, because change will begin with you, with me. This is how we change. So finally, the sun is rising every morning, and it brings love with hope to the suffering poor and to all those your lives touch. And we pray that you may continue to do that wherever you are. Thank you for listening.
Wow. Thank you very much, Dr. Merriman. I think most of us here are quite emotional after listening to you. And I think it's very important that that you bring out also the emotional aspect of care, because I think that was a fantastic presentation. By the way, thank you very much for sharing all the wisdom. I always, when I'm teaching or talking to healthcare workers, I always say we should not be scared of what we used to call TLC. What we still call TLC in medicine, that is tender loving care, because we are taught mostly to hide our feelings, not to get close to patients, not to love or care. But if we are not tender and we don't love and we don't care, there's no way we can do what you're telling us to do. So thank you so much for reminding us that we need to be caring, we need to be tender, we need to be loving. And I think, as you have said, as much as we can, we should try to aim to cure our patients. But sometimes we are not able to cure. So we should always be able to relieve their suffering, whether it's physical, emotional, psychosocial, or spiritual. But the most important thing, again, is we should always comfort our patients and their families. And it's good that we remember these things, because sometimes, as you'll see, some of the questions when you go to them are talking about putting money before the patient and family. How do you deal with such things? So thank you very much. I think the issue of touch, you talked about touch, you talked about empathy, and the issue of that when patients see us, they want us to give them what's in our heart. And I think that's very important. And I think this is really touching on all the ethos surrounding what palliative care is. We'll go to question and answers, and then maybe as we discuss in the question and answer, we can have again more discussions. So I will start with some of the questions. We've been having about 70 to 75 participants from many parts of the globe, which is really fantastic. The first one, Dr. Merriman, is from Eda. She says, how do you combine natural medicine, for example, herbal, with conventional medicine? And I think she asked this because we live in a continent where our herbalists are really key in our treating our illnesses. How do we combine these two? And I know Uganda has done very well. I remember there's a time we had a meeting and we had a herbalist, a doctor, a medical doctor who had gone to Makerere University, trained as a conventional medical doctor, but had actually switched to herbal medicine. So how do we do this? How do we combine both so that they benefit our patients?
Thank you for that question. And I'm glad you mentioned it, because I believe that a lot of the traditional medicine does really help patients, and particularly if they've been taking it all their lives. And the second thing is that the traditional medicine, if you believe in a medicine, you're almost 50% round to it working for you. And I've seen patients move from our care onto traditional medicine, and because they really believed in it, you know, and it just looked like, well, we saw the medicine and the cost of it was huge, you know. But so my approach, and it was not just here, it was when I was in Singapore and Malaysia as well, I saw, you know, people believing in traditional medicine. And if as long as it's not doing them any harm, we allow them to continue with it. But let me tell you that during COVID, we had patients who stayed at home. They believed they had COVID. They made a concoction of eucalyptus and several plants, garlic and different things like that. And then they inhaled it, and it helped their breathing, and it probably upgraded the oxygen profile as well. And then also they started to drink it 3 times a day. And well, as far as we know, they got better from that. So, you know, I think we have to be, you know, we can't condemn it. The only problem with traditional medicine, it's not being proved by research. But that's how we started everything anyway. Most of our medications arose from plants. The morphine did, the digoxin did. Many of them came from plants. And it was only when the research was done that it was accepted by the medical community. So let's believe in it.
Thank you so much. I think tradition is really important. When I had mild COVID last year, despite being a medical doctor, because I wasn't going to be admitted, it was mild. I actually did those concoctions you're talking about. I didn't do the eucalyptus, but I did the ginger, garlic, and lemon, and honey, and they helped. So traditional medicine has its place as well, its role in our patients' care. The second question is from Christina Montanez. She says, Dr. Merriman mentioned the concern about medical social school training. Students go in wanting to help and come out wanting to make money. As an educator, this is very concerning to me too. What can we do to make the shift from this mentality?
It's a difficult one, but I think it's the example they get. You know, when I was teaching in Makerere, even the first lecture I went to, I think there was only 3 turned up. And I said, but why? Why aren't you, you know, why is there only 3 turned up? And they said, because usually the lecturer doesn't turn up. He's going to do his private practice. And I said, well, listen, I'm going to turn up. I'm not paid, but I'm coming. I'm going to. And they came after that. And they did come because they knew I was going to be there every time. But you see, it's the example they get from their teachers, and not just their teachers, but when they go into clinics and they see things happening, which is around money, and see patients being turned away because they don't have the money. And it's really so difficult. And I've seen patients in other countries, not so much in Uganda, being turned away when they're in agony because they can't pay 10,000 shillings. No, $10 they were looking for in Nigeria for 250 mils of the green morphine. You see, and there's always somebody behind that wanting to make money. And, you know, money has become the center of care sometimes instead of the patient being the center of care. Yeah.
Thank you so much. Yeah, that can be a problem also. So the next is somebody from Uganda, Mutebi. She's a clinician from Uganda. It's her first time to attend the webinar, and she would like to join the team. So Mutebi actually will not be able to answer how you join the team, but I think the Ugandan team can reach out to her and find out how Mutebi can join the hospice and palliative care fraternity in Uganda. You can reach out to Dr. Anne Merriman, you can reach out to Rose. There are quite a number of people on this webinar that are from Uganda. You can also chat with them and see how you can join the team. Thank you so much for wanting to join the team, and you're very welcome to join the fraternity. We want more and more people to join us. And again, Mutebi is asking, my question is, what is ethos in palliative care? Which I think is what Dr. Anne Merriman has talked about the last 1 hour. but maybe she can summarize in a sentence. And maybe as you summarize in a sentence what ethos is in palliative care, so that we can move to the other questions, is maybe you can also talk, Dr. Anne Merriman, about the degree, the measure, if you have any indicators to measure the degree to which a palliative care ethos is effectively implemented.
Wow. I think I've got it right. How do you measure how well the palliative care is being implemented individually? Because it's different in every situation. You know, there's something that nearly 90% of the districts in Uganda have at least one nurse who can prescribe morphine, because our nurses have been able to prescribe morphine since 2003. And yet you see that she can't do the whole district. She's by herself. She's working for a government, and she can't get out and see. So we say, okay, we've got somebody there, but at the same time, she's not going to make it out to those people. Now, what they're measuring, the way they're measuring it in Uganda is they're measuring the people that are receiving morphine. Of course, that's a very wide thing, because people receive morphine for sickle cell and for burns and for sometimes even post-operatively. And, you know, so, you know, it's a very wide thing. But at the moment, we estimate about 10% get palliative care. But the standard of palliative care is what you're looking for. And Kehpca came up with one, I think they called it the POS, was it the POS? Thing where you could interview patients and relatives to see what, see, and that does help. That gives you some advantage of understanding which way you're going. But it's a very important question, that it's because it's very important that we do measure the standard of care as measured by the patient and the family. Yes,
I think you're right. The correct information comes from the patient, because the patients are the ones who are receiving the care and can tell us if it's improving their quality of life, which can also be very subjective, because maybe for me the most important thing is spiritual care. For somebody else, it's, you know, the financial support. For somebody else, it's the pain management. But we do have tools that we use. The African Palliative Care Association has the Kehpca POS tools that can actually also help understand about the care we are giving to our patients. Natalia and Beatrice are saying, thank you very much, Dr. Anne Merriman, for the wonderful presentation and the wonderful work you're doing. They are both from, I think, Uganda. Natalia is also asking, what do you do in terms of the care of the carers to the palliative care team, since this involves a lot of irresistible emotions? I was also going to ask about the same issue. When the patient tells you, I want what's in your heart, and when you give all that you want to give, the issue of burnout, because I have gone through that, and it was very intense when I had to step out from the hospice because of burnout, because of getting over involved. How would you advise us to deal with this, Dr. Merriman?
I think the conflict is there. I don't think we can get too involved with the patient. I mean, unless you suddenly start crying in front of the patient and things like that. But mind you, I've seen our nurses crying when somebody's died. You know, even with the family, they cry with the family. And you see, to me, that's not demeaning. That's even, you know, it's showing them that they really did care and that they still do care for the family after the patient is gone. But see, I don't see many patients these days, but the few patients I have seen recently have been people that I knew well. I was asked to see them because they asked for me. And I find that I get very close to them, but I seem to be able to cope with that. But then I'm doing it a long, long time, you know. I think when I was in Singapore, when we were starting their home care, I never cried in front of them, but I often cried in the car on the way back home, you know, because, you know, it was very, very moving, very emotionally moving. And now, how do we care for somebody like that? A lot of people will have a good cry and that's the end of it. But some people, you can see they're under stress. They're under a lot of stress, and you have to be aware of this. And I think you need a good person in charge of the clinical team that will identify that. And this is the second one of the ethos, the second pillar, that we care for each other and we identify if there's a problem and try to support them, and maybe even give them some leave if necessary over that time.
Yes, thank you. I think most hospices usually focus on having a support system within the care team, so that there's somebody can troubleshoot. And we used to tell people, you know, if you find it's too much, take a break, go home, go do your hair, do your nails, especially most of us working in palliative care being ladies, or we would have a meal together, you know, cook a meal at the hospice together and eat it. And that's really like lunch, you know, have our own meal. That really helped a lot. So there are mechanisms you can use. Like Dr. Anne Merriman has said, that sometimes your tears will roll down, especially if you go to a patient who has just passed away and the family has called you, maybe to issue the death certificate or, you know, the burial permit, whatever. And then they come on you, they hug you and they cry. You're a human being, the tears might roll. And I don't think we should be embarrassed that our tears are rolling. Somebody has asked a very interesting question, and I know that some people sometimes, and I know Dr. Muir is on this call, she always also could even help respond to this after Dr. Merriman responds. So somebody says, why does palliative care seem more for the poor?
Yeah, I've been criticized for this and saying the rich need palliative care too, but what happens to the rich? They go to the private hospitals, very often where there's no palliative care. And the reason behind that is very often because, well, they tell me that their relatives will condemn them for not giving them the best care if they don't go to the hospital. So palliative care has to be seen as the best care. Now, why the poor? Because the numbers of people that don't ever reach healthcare. You know, and they're just going, I mean, you know, in UK now, everybody gets, if you're diagnosed with cancer, you're fast tracked and you get treatment, and many people survive. But here, they're dying, they're just dying there, but they're dying in a terrible way. So it's a difficult question, but I hope I've been trying to explain that.
Yeah, I think mostly because I usually say in Kenya, it's because maybe when it started because of the suffering of the poor. For example, Nancy, the story of Nancy, who was a patient in Kehpca living in very, very poor conditions. And so people kind of thought it's a poor person's service. But if you go to Nairobi Hospice, we took care of ministers, we took care of very rich guys, you know. So it's not really for the poor, it's for everyone who is in need of palliative care. It's for everyone, irrespective of their socioeconomic status, their religion, their age, their gender. It's for anybody who is in need of palliative care. So we should not discriminate. And the other question is from Dr. Miriam Mutebi. She says, great and inspiring talk. As an educator, one of the issues I have been grappling with is how we can teach empathy. We used to think it was intuitive and we could show and model by example, but this doesn't always translate. I would love to hear your thoughts on how to proactively Dr. Mutebi, your English, inculcate this into the health worker training.
Incorporate it into the medical school and into the nursing curriculum, is that it?
Yes, how do we, she says, how do we make it as part of our training? How do we, you know, inbreed it into the people we are training so that it's part of what they do?
Again, you know, we had it in the medical school from the second year we came in 94. And patients came, we taught it in the medical school, we brought them into the homes. Since 2008, we taught a while there, and the students used to come for a week. But for the last 2 or 3 years, they're not coming at all. And this upsets me very much because most of the initiators that we bring in from other countries, they've never been in a patient's home all their lives. They were brought up in a hospital and they trained through there and they've worked there ever since. And they're so moved, they, you know, once they see something. And so it's really so important that we are that we're aware of this and that we get this into the undergraduate curriculum. It's also in the nurses' undergraduate curriculum. Now, we have a special course for nurses which gives them a diploma, allows them to prescribe morphine. And we've been using that for years. And now also Malago, which is the National Referral Hospital, has taken it on, teaching their nurses to do a similar course. And so in that way, we're getting more nurses that can do it. And now, one of the good things that the government has done is that they say that every government hospital must have a palliative care unit. That is a great thing. And that's just about, it's coming off the ground now. But it once they're in there and they see the good that these palliative care teams are doing, we get respect from the other doctors, because I seem to spend my life going into it started off doing surgery and obstetrics and gynecology and all the rest of it. And it was all very exciting and very glamorous. But, you know, I went into geriatric medicine and palliative care, and both of them were looked down on by my colleagues. And yet there was so much need, you know. So I think, you know, you've got to stick to it, really, if you have that desire to help the people in most need. Yeah.
Thank you. I think as healthcare workers, we need to keep up the advocacy and never give up, because we will never really get to the level we want to. It will take years. So I think Dr. Mutebi and what Dr. Anne Merriman has said, I think we have to be examples. We set examples, and I think if you look at the scriptures, we are told that if you set an example of what Christ did, then people see that goodness in you and they want to be like you. So setting that example is very important when you're with the young doctors and nurses and clinical officers, social workers. As you do the ward runs, they actually, observe what you're doing, and and then it can change their attitude and say, I want to do the same thing. So that's very important. And somebody, Anonymous, Mr. Anonymous or Mr. Anonymous, is asking, what is the greatest barrier to the ethos taking root?
Could you repeat that, Zippy?
What is the greatest barrier to the ethos that you've talked about taking root? What do you see as the greatest barrier?
When your team grows very big, it's very hard to maintain the ethos. When we started and there was just a few of us, and those people who were with me when we started, they're the people that hold the ethos and hold the vision, and are the ones that are going to help us to move into the future. But even they're retiring now, and you see, but you've got to pass it on, and you've got, whether you're in a hospital with a palliative care unit and they move you into obstetrics where you're not going to use it, or you may have to use it at a very rapid stage, but even then, you need to be. If you move out of your job, make sure somebody else is trained in it, because more often they put somebody who doesn't know anything about it in it. And that's in a hospital. But in the hospice itself, I think as we get new people coming in, we have to have them trained in the ethos and in the spirit, and to realize, you see, because if you've been always working in bureaucratic things where things went, by order, you had to do this. And I think of the Hippocratic Oath, and I think, well, I know this is what should be done for this patient, but somebody up there is ordering me to do something different. What do? I'd be rebelling, I must say, but I'm glad I'm not in that situation anymore. But it's a difficult thing, yeah.
Thank you very much, Dr. Anne. Elizabeth is asking, at what point should palliative care begin?
At what point?
At what point should palliative care begin? When do we start palliative care?
Yeah, WHO said as soon as an end-of-life condition is diagnosed. That was what they said in their first definition. But in fact, when we came here, and I think it happened in all the countries that I went to for the first time, people sent them about a day before they were about to die anyways. You need to be there in time to know the patient and to know the family. You can't walk into somebody who's dying on their deathbed and, do what's necessary, because you can't really help them at that point. So it should go in as early as possible. I would say as early as possible. But of course, people who are dying at home, they're not going to get them till the last minute anyway.
Okay.
But, yeah.
Thank you very much, Elizabeth. So Nasur is asking, well, it's not a question, I'll answer this. She says, great presentation, Dr. Anne. Thank you, she says. And she's asking when we will have our link to the recording. Nasur, actually, this is also being watched on Facebook. We have quite a number of followers right now watching this on Facebook Live. I think, Howard, you can respond. It will be on Facebook for how long? Live for how long? And is it possible? We don't have everybody's email here. Maybe through the registration, we'll be able to get your emails and send you the link to the recording. Esther Mwinga is typing an answer. Dr. Esther Mwinga, you can unmute yourself and just say that answer. You are what is it? a facilitator there. So
Yeah.
would you like to unmute and give that answer?
The Facebook Live link will be there. It will be there permanently. So, but the recording link, if someone requests for it, we'll be able to send it.
Okay, so if they have to write to you or you send it to them since they're registered, people might actually just want to keep this so that they can listen to it at their own time to internalize everything that has been said today.
It's good if you can send out a link to people, yeah.
Yeah,
Yeah.
so
Okay.
yeah, but
I'll
it will
send
be
the
live
link.
on Facebook as well. It will still be on Facebook for some time.
We're not allowed to watch Facebook in Uganda, you know.
Oh, all right. Okay, so if you have a Facebook account, you can still watch it on Facebook. Right
It will
now,
be
you
on
have quite a
Facebook permanently.
yeah. Okay, it will be there permanently. We do have quite a number of Kenyans right now watching it on Facebook, and other people again from other parts of the world. So, is there anybody with any other burning question? We've come to the end of the questions that are listed in the Q&A. Okay, Njoki is asking, hi everybody, great webinar. Someone has asked about how to inculcate empathy. Compassionate care is increasingly being taught in the nursing curriculum in England, and one may find the material relevant to include in curricula. Many thanks, this has been very insightful. So Njoki, maybe you can later on share with us the links to those materials and we can share with people as well. And maybe other countries, we need to take an example from England, the England curriculum as well. Thank you for that contribution, Njoki. Is there any question that we have not responded to? I think we've responded to all of them. Yes. So we have 5 minutes left. If there's no more questions, Dr. Anne Merriman, I would like you to give us some parting shots, some words of wisdom before we close this session, before we give a vote of thanks and close the session.
Just to say that if you really get involved with palliative care, it will really change your life. It's really, I have been committed to it for so long, but I would never look back at my life and say, I wish I'd done something else. I've been in so many different specialties I started in Nigeria where I had to do everything. I even had to remove legs, and my first major operation was a splenectomy. And, you know, and yes, nothing has given me so much joy as it has been. And as you all know, when you visit a patient and you see them in misery and then suddenly they're smiling because their pain is relieved, because they can now talk to their relatives and they can share things. They can share their problems. They can share what they want to happen after they have gone. And this makes such a difference. And they appreciate you so much. My goodness, the patient in the ward is not going to tell you how much he appreciates you, but you go into somebody's home and I'm telling you, they will really tell you how much they appreciate the fact that you have come, and you get to know them so well. And to me, I've learned far more from patients than I've learned from any books, and particularly with African patients.
Thank you so much, Dr. Anne Merriman. Somebody, Alex Bloomer, has asked a question, Christina Montanez, at the last minute. So I'll give her, since it will be the last one we'll be taking, and since she's joining us from, I don't know which part of the world, it must be quite far. She's saying, is it possible to start a network of people who want to carry on this conversation and continue Dr. Merriman and her team's legacy? We are the next generation of palliative care leaders, and we need to continue to draw upon your wisdom. Dr. Anne Merriman, is it possible for you to type your email on the chat?
Yeah, okay. On the
Yes.
chat. Okay.
Yes, are you able to do that, or yeah?
Yeah, I will give you.
And yes, I agree with Christina. We need to build, to mentor, to work together with the new generation. And we have quite a number of people in Kenya now working in palliative care. I think close to 300 healthcare workers, 90% or 95%, 90% who are probably nurses, and quite a good number of social workers, a few doctors and pharmacists. So this network of the next generation that is probably quite innovative and dedicated is very important. If we could really help mentor this generation, it would be a fantastic thing. So Dr. Anne Merriman is typing her email, or Howard, you have Dr. Merriman's email. You can type it there.
Yeah, I put it in.
Okay, fine.
That's that.
So yeah, we can continue that conversation with Dr. Merriman and the rest of us who have also been in this field for long. I see Dr. Mnyoro is on the call, myself, even Dr. Faith Mwangi. She is also good in terms of understanding the advocacy around palliative care. Colleagues from Kehpca, colleagues from APCA, colleagues from Hospice Africa, Uganda. Yeah, we're always willing to work with others to ensure that this does not die. Palliative care does not get, sidetracked in any way. So yes, Dr. Anne Merriman, we really thank you. We've kept you for so long, and really thank you so much, because you are really an inspiration. For many years you have done this. You left your own country, you left the comfort of your country to come and work in Africa at a time when really Africa was crying for so much help, and especially at a time when Uganda was crying for so much help, post-war issues, HIV, AIDS, no morphine in Africa. You brought the first morphine to Africa. We really are very grateful for what you've done over these past years, and we want God to give you more years so that you continue mentoring and being the cornerstone for the rest of us. Thank you very much, Dr. Merriman. I also wish
Thank you
to thank
so much, Sophie, and thank you everybody for listening.
Thank you. I want to thank all those who have taken part in this session. We were hitting between 70, 75, 73. People have internet connection issues, but also we have another crowd following us right now on Facebook. We want to say thank you very much to everybody who has listened to this session. Please take back what you have learned. Remember the TLC, the touch, the empathy, empathizing with patients is very important, and their family. Our unit of care is the patient and the family, and not necessarily a disease. As we were told, it's not about the disease, it's about the person, who has that disease. So let us remember that. I want to thank the Kehpca team who are behind the scenes. In case anything should happen, Esther Muinga was there, David Busoki was there, and of course Howard, who is our communications officer, and also doubles as our IT person when we are having these sessions. Thank you very much, Howard. Thank you very much, everybody. Thank you very much. Until in the next session, which will be another 2 weeks' time, you'll all receive an alert about the next session. We will try to do also other things. And so please remember to join, and thank you, everybody. If you haven't had your dinner, I wish you a very, very nice dinner. Bon appetit, and have a lovely night and the rest of the week. Asante sana, Dr. Merriman. Thank you.
Thank you very much.
Thank you. Howard, you can end the